Welcome back to the Deep Dive. This is where we take really comprehensive, sometimes pretty dense source material on one specific topic. It could be science, history, whatever, and we boil it down. We get you that essential, nuanced understanding you need to be, well, truly informed.
And today, our focus is ADHD, attention deficit hyperactivity disorder. It's a neurodevelopmental condition, incredibly common, actually, but also profoundly misunderstood, I think.
Right.
Even with decades of clinical agreement, public perception often gets stuck on, stereotypes, just kids who can't sit still.
Exactly. And that's why we do this. We've gathered a lot of research here covering the deep genetic stuff, the brain's unique wiring,
Yeah.
the complex impacts across a whole lifetime. We're aiming to take you straight to the core of it.
Yeah, our goal is to show that ADHD is fundamentally about, well, excessive and pervasive symptoms, things like inattention, hyperactivity, impulsivity, and it's all rooted in this key difficulty, executive dysfunction. Think of executive function as the brain's air traffic controller. And in ADHD, well, let's just say that controllers may be taking an unscheduled break, often.
Right. So for you, the learner, listening in, and we're going to get into that weird paradox of hyperfocus, look at why ADHD messes with standard IQ tests sometimes, uncover that huge 70 to 80% genetic link, and, yeah, discuss some pretty sobering data near the end about quality of life and even life expectancy. Let's dive in and really unpack this.
Okay, so when we talk about ADHD formally, clinically, we have to look at the diagnostic manuals. The main ones are the DSM-5-TR, that's the Diagnostic and Statistical Manual, and the ICD-11, the International Classification of Diseases. They lay out the criteria.
And the core idea is that symptoms are just fleeting, right? They have to be excessive, pervasive, last for at least 6 months.
That's right, 6 months minimum. And crucially, they need to significantly interfere with or reduce someone's functioning, and not just in one place.
Ah, yes, the multi-environment rule. It can't just be trouble at school. It has to affect, say, school and home life, or work and social interaction.
Precisely. Pervasiveness is absolutely key for a clinical diagnosis. It shows it's not just a reaction to one specific stressful environment.
Okay, and the DSM-5 also has that age of onset thing, symptoms present before age 12. Why is that important, but also maybe a bit debated?
Well, the idea behind it is to establish that it's truly neurodevelopmental, starting early in brain development, and not something acquired later due to, say, a recent trauma or extreme stress. It points to an underlying difference in brain wiring.
But you said debated.
Mm-hmm.
The research suggests maybe clinicians shouldn't be too rigid about that age 12 cutoff, especially for adults.
Yeah, there's nuance there. It acknowledges that some people, maybe particularly bright individuals or those in really structured, supportive environments, can develop pretty sophisticated coping mechanisms early on.
Ah, so they mask the symptoms.
Effectively, yes. These strategies might work fine until the demands really ramp up in adulthood, managing a job, family, finances all at once. Suddenly, those coping mechanisms get overwhelmed. The underlying symptoms were probably there before 12, but the impairment didn't become obvious or maybe even problematic until much later.
That makes a lot of sense. Okay, so based on the clusters of symptoms, the sources talk about three main presentations, like different flavors of ADHD.
Right. First up is the predominantly inattentive presentation. Used to be called ADD sometimes, now ADHD-I or PI. This is where the main struggle is with things like organizing tasks, staying focused, following instructions, keeping track of belongings, losing things.
The classic daydreamer kid, maybe.
Often, yes. Or the adult who gets easily sidetracked, maybe tunes out during meetings, or gets lost in their own thoughts constantly. That internal distraction can be really significant for adults.
And this is the one sometimes missed, right? Especially in girls, because it doesn't have that obvious disruptive hyperactivity.
Exactly. Which leads us to the second type. The predominantly hyperactive impulsive presentation, ADHD-HI or PH. This is the more classic image many people have.
Okay, what does that look like?
Constant fidgeting, squirming, difficulty staying seated when expected to. In adults, it might be more of a feeling of restlessness, like they always need to be moving. Also, excessive talking, blurting out answers, trouble waiting their turn, interrupting, just acting without really thinking things through.
That lack of forethought.
Yes, that impulsivity. It's much more visible, often disruptive in a classroom or workplace, so it tends to get noticed earlier.
And the third one?
Is the combined presentation, ADHD-C. This is when someone meets the criteria for both the inattentive cluster and the hyperactive impulsive cluster.
Got it.
And historically, this combined type is the one that's been studied the most. Now, a really important point here is the developmental shift. The idea that people just outgrow ADHD, that's a myth. Our sources are very clear on this.
So the core problem that executive dysfunction doesn't go away?
It persists. But the way the symptoms look can change dramatically as people get older. They morph.
Okay, let's talk about that morphing. How does that visible external stuff change, like the kid running around versus the adult?
So in childhood, you see that obvious gross motor stuff,
Yeah.
running, jumping, climbing when it's not appropriate, difficulty sitting still through dinner. You also often see related issues like maybe delays in speech or language, some motor skill challenges, and often really messy handwriting reflecting issues with fine motor control and sustained effort.
But adults aren't usually climbing the furniture in meetings. So where does that energy go?
It goes inward. That overt physical hyperactivity often transforms into this profound sense of inner restlessness. Adults describe it as feeling constantly keyed up, like their mind is always racing and need to be busy doing something. It makes it incredibly hard to just relax or switch off, especially at night.
And what about the impulsivity, cutting in line as a kid versus adult life?
Adult impulsivity has much bigger stakes. It can look like sensation-seeking, maybe driving too fast, risky behaviors. It can be impatience, like road rage, or getting easily frustrated in conversations, quick-tempered reactions in relationships, difficulty stopping yourself from saying the wrong thing at the wrong time, and a big one is financial impulsivity, reckless spending, getting into debt.
So the behavior looks different, but it's still that underlying difficulty hitting the brakes, that executive function failure.
Exactly. The core struggle with inhibitory control remains constant, just manifesting in age-appropriate and often more damaging ways. All right, so we've covered the official diagnostic boxes, but let's get into the stuff that really shapes the day-to-day experience, the nuances. And a huge one that many clinicians feel should be in the manuals is emotional dysregulation.
Right, this comes up so much. Why isn't it a formal symptom cluster in the DSM or ICD if it's so common? Is it just too hard to measure?
That's part of the debate. It's complex, but clinically. Emotional dysregulation or mood lability, big swings in mood, is seen as incredibly pervasive. It probably affects the vast majority of people with ADHD. We're talking about difficulty managing emotional responses.
So like really intense reactions to relatively small things and trouble bouncing back.
Exactly that. Getting overwhelmed by frustration or disappointment and then finding it really hard to shake it off and move on. The emotional volume knob seems stuck on high and the recovery time is slow.
And you can immediately see how that would impact relationships, can't you? If your emotions are all over the place, maintaining stable connections must be tough.
Absolutely. It's a major factor in the relationship difficulties we see. People with ADHD often struggle with the complexities of social interaction, not just making friends, but keeping them. The research is pretty stark. About half of kids and teens with ADHD face social rejection. That's way higher than their peers.
What causes that rejection, usually, is the impulsivity, blurting things out.
That can be part of it, but it's also often about missing subtle social cues. Sarcasm, shifts in tone, body language. Reading those cues quickly relies on good processing speed and working memory, which can be weak spots. Or during a conversation, just zoning out due to inattention.
Making the other person feel ignored or like you don't care.
Precisely. They might come across as uninterested or maybe unreliable because their focus drifts. It makes navigating the social world really challenging.
Okay, let's shift gears to something fascinating and often misunderstood. Hyperfocus. You hear this term a lot. If ADHD is an attention deficit, how can someone hyperfocus?
It's the perfect illustration that ADHD isn't really a lack of attention, it's a problem with regulating attention. Hyperfocus is the state of really intense, narrow, and prolonged concentration on one specific thing.
Okay, but only on certain things, right? What usually triggers it?
Typically tasks that are highly stimulating or provide immediate feedback and reward. Think video games, coding, deep diving into an internet research rabbit hole on a topic they love, maybe intense online chats, or getting lost in a creative project.
Because the task itself is inherently rewarding. The brain doesn't need to work so hard to stay engaged.
Exactly. The dopamine system is already fired up by the activity itself, so the brain doesn't need to rely as much on its internal, often weaker executive control systems to maintain focus.
That actually sounds like a superpower sometimes. Where's the downside if it's listed as a symptom?
The downside is the lack of control over it. While, yes, it might let someone power through a specific interesting project, clinically, hyperfocus is linked to this concept called perseveration.
Perseveration. Can you break that down for us?
Sure, perseveration is basically getting stuck. It's the inability to disengage from something, to shift your attention away, even when you need to. Imagine you're watching a really absorbing movie, but the fire alarm goes off.
Mm.
Perseveration is struggling to pull yourself away from the movie to react to the alarm.
So you're locked in, even when it's detrimental.
Yes. That prolonged, excessive attention means neglecting other important things. Forgetting to eat, missing appointments, ignoring people trying to talk to you. And it can link to more serious risks like internet or gaming addiction, or even getting locked into risky behaviors because the ability to stop and switch gears is impaired.
Wow. That really highlights it's about regulating attention, not just having less of it. Okay, let's move to cognition, another tricky area. ADHD and IQ scores.
Right. This needs careful handling. On average, studies do find that groups of people with ADHD score lower. The figure often cited is around 9 points lower on standard IQ tests, but that headline number is really misleading if you don't look deeper.
Yeah, I was going to ask about that. Does that 9-point difference actually mean people with ADHD are inherently less intelligent? Or is something else going on? Is the test itself maybe not capturing their real abilities?
It's much more the latter. The issue isn't typically overall intellectual capacity. The problem is that the full-scale IQ score, the main number people look at, relies on averaging results from various subtests, and it assumes these subtests are all strongly related, reflecting some general intelligence factor.
But in ADHD, some specific subtests get hit harder than others.
Exactly. The scores tend to drop significantly on subtests that heavily measure working memory and processing speed.
Okay, define those quickly. Working memory is like...
Your mental blackboard. Holding information in mind and manipulating it like doing math in your head or remembering multi-step instructions.
in processing speed.
How quickly and efficiently you can perform simple, often timed tasks, scanning information, making quick decisions.
So if those specific functions are weaker due to the executive dysfunction of ADHD, they drag the overall average score down, even if other areas like verbal reasoning or spatial skills are strong.
Precisely. The test ends up measuring, in part, the impact of the executive function weaknesses on test performance, not just pure intellectual potential. Think of it like having a really fast computer processor, intelligence, but the operating system, executive function, has limited RAM, working memory, and runs kind of sluggishly processing speed.
Gotcha. The underlying ability might be high, but accessing and demonstrating it efficiently under test conditions is the problem.
Exactly. And that's why newer scoring methods exist for tests like the WAIS and WISC. They allow clinicians to calculate an IQ score that gives less weight to, or even substitutes, those working memory and processing speed subtests. This gives a much clearer picture of the person's underlying cognitive strengths, less clouded by the executive function challenges. It also helps explain how some very bright kids manage to compensate for years their high intelligence finds workarounds for the functional deficits until life gets too complex.
Okay, let's shift from symptoms and how ADHD looks to what's actually causing it. And the sources we reviewed are incredibly clear on this point. ADHD is fundamentally biological. It's highly genetic.
Yeah, the evidence here is just overwhelming. It's one of the most robust findings in all of psychiatric genetics. ADHD has a heritability rate estimated between 70 and 80%.
70 to 80%. Can you put that number in context for us? How does that compare to other conditions?
It's extremely high. It's up there with things like height or other major psychiatric conditions like bipolar disorder or schizophrenia. It means genetics are far and away the biggest contributing factor.
And when we say genetic, it's not like there's one single ADHD gene, right? It's more complicated.
That's right. It's polygenic. That means it arises from the combined small effects of many different genes, hundreds, potentially thousands accumulating. Many of these genes seem to be involved in brain development or how neurotransmitters, those chemical messengers in the brain, are produced, transported, and received.
Which explains why it runs so strongly in families.
Absolutely. If you have a child with ADHD, their siblings are about 3 to 4 times more likely to also have the disorder compared to the general population. The genetic loading is significant.
Okay, let's use this moment to really hammer home a point and bust some persistent myths. If genetics account for 70–80%, what about the other 20–30%? Because you still hear things about bad parenting or sugar.
Right, and the research is definitive here. That remaining variance is primarily down to non-shared environmental factors, things that happen uniquely to one individual. This could be random, spontaneous genetic mutations, de novo mutations, or significant disruptions very early in brain development. Things like prenatal exposures or birth complications. What it is not significantly driven by, according to solid research, are factors like bad parenting, family stress, poverty, or eating too much sugar.
So those things might make symptoms worse or harder to manage, but they don't cause the underlying condition.
Exactly. That distinction is vital. Stressful environments can absolutely exacerbate ADHD symptoms, but they aren't the root cause. The root cause is biological.
Okay, so sticking with biology, what are those non-genetic environmental risk factors that do play a role, usually very early on?
Yes, the timing is key. These factors impact brain development either before birth or very shortly after. One major one is traumatic brain injury, TBI. It's thought to account for maybe 5% of ADHD cases overall. And the link goes both ways. Kids who have a TBI are at much higher risk, maybe 30% or more, of developing ADHD afterwards.
Wow, 30% after a TBI, that's huge. What else?
Being born extremely prematurely or with a very low birth weight are also significant risk factors. This points towards disruptions in the final, critical stages of brain maturation. And then there's prenatal exposure to certain substances. Alcohol and nicotine are major ones. Exposure to environmental toxins like lead or PCBs during pregnancy can also increase the risk. Essentially anything that interferes with the intricate process of early brain development.
Okay, let's look inside the brain now. What's going wrong at the core level? The pathophysiology, you mentioned neurotransmitters.
Yes. The core issue in ADHD seems to involve functional impairments in key neurotransmitter systems, especially dopamine and norepinephrine. These chemicals are crucial for regulating executive functions.
Dopamine. People often link that just with pleasure, but it's more complex here.
Much more complex. Dopamine is critical for motivation, for determining what's important enough to pay attention to, salience, and for reinforcing behaviors. Norepinephrine is more involved in alertness, vigilance, and responding to novelty. Think of them less as simple messengers and more as modulators. They fine-tune brain activity, especially in the prefrontal cortex.
And in ADHD, these systems are underactive, out of balance.
Functionally impaired is the term often used. The signals aren't being modulated correctly. This leads to problems sustaining attention, especially on boring tasks, controlling impulses, staying organized, and regulating alertness levels. It's like the brain's signal-to-noise ratio is off.
And do we see physical differences in the brain structure itself?
Yes, consistently. Neuroimaging studies show, on average, subtle but significant differences. There tends to be a general reduction in volume in certain brain areas, particularly in the left prefrontal cortex.
The prefrontal cortex, that's the brain's CEO, right?
Yeah.
Planning, decision-making.
Exactly, the highest level of cognitive control. We also see differences in areas like the posterior parietal cortex, which is involved in attention and spatial awareness, and sometimes in the basal ganglia, which relate to reward and habit formation. It's not one single spot, but key networks involved in executive control appear to develop differently or be slightly smaller, particularly during childhood and adolescence. Less volume and potentially altered connectivity in these networks means that air traffic controller we mentioned just doesn't have the resources or connections to manage everything smoothly.
And understanding this chemical imbalance directly explains why stimulant medications work, even though it sounds counterintuitive for hyperactivity.
Precisely. It seems paradoxical, but stimulants like methylphenidate, Ritalin, Concerta, or amphetamines, Adderall, Vivance, work directly on those dopamine and norepinephrine systems. They increase the levels of these neurotransmitters in the synapses, the gaps between nerve cells.
So they're boosting the signal.
Essentially, yes. They enhance the communication within those crucial brain circuits, particularly the pathways connecting the midbrain to the prefrontal cortex, the mesocortical limbic pathway, and the locus coeruleus system for norepinephrine. By improving the neurochemical environment, they help the prefrontal cortex do its job better, improving focus, reducing impulsivity, enhancing working memory. They help normalize brain function.
Okay, one last biological point from the sources, this paradoxical reaction thing. What's that about?
Yes. That's a really interesting clinical observation. About 10 to 20% of people with ADHD report having unexpected, often opposite reactions to certain psychoactive substances.
Opposite reactions, like what?
Well, for example, a local anesthetic at the dentist might make them feel agitated or wired instead of numb, or a sedative, like some antihistamines, might make them hyper instead of sleepy. Conversely, some find that caffeine, which is a stimulant for most people, actually has a calming or focusing effect on them.
So that their brain chemistry just processes these things differently.
It seems so. It's considered another potential sign of that altered signal processing, likely tied back to the underlying genetic differences affecting neurotransmitter systems. It's consistent enough that some clinicians might actually ask about family history of odd reactions to medications or caffeine as part of their assessment. It can be another small clue pointing towards this neurobiological profile. Okay, so we know ADHD is biological, but diagnosing it isn't straightforward. It relies on observing behavior and assessing development, not on, say, a blood test or a simple scan. And that opens it up to criticism, right? Questions about subjectivity.
True. But the counterargument, like from that international consensus statement you mentioned, is pretty strong. They point out that trained professionals do agree on the criteria, and crucially, the diagnosis actually predicts things really well, future risks, outcomes, even how someone will respond to treatment. It has validity in that sense.
Absolutely. The process itself, when done properly, is thorough. It involves gathering information from multiple sources, parents, teachers, the person themselves, if they're old enough, often using standardized rating scales. Things like the Connor scales, the Vanderbilt, the ACEBA.
But here's a catch you highlighted from the sources. Those rating scales, while internally consistent, the agreement between different raters isn't always great.
Yeah, that's a key challenge. The reliability between raters like a parent and a teacher rating the same child is often only poor to moderate.
Why is that? People just see things differently.
Partly. But it also reflects that behavior is context dependent. A child might hold it together in the structured school environment, but fall apart at home where demands are different. Or vice versa. One environment might trigger hyperactivity, another might trigger inattention more.
So you absolutely need information from multiple settings to get the full picture.
Definitely. Relying on just one perspective gives you an incomplete, potentially biased view. Triangulating information from home, school, and self-report for older individuals is essential.
And speaking of bias, we have to address the systemic issues. The sources pointed out potential racial and socioeconomic biases affecting diagnosis rates.
Yes, this is a significant concern, particularly highlighted in U.S. data. Studies show non-white children are often less likely to be diagnosed with ADHD or receive treatment, even when they show similar levels of symptoms to white children.
Why does that happen? Access to care.
That's a big part of it, disparities in access to specialists. But it could also involve implicit biases in how behaviors are interpreted. For example, a teacher might view disruptive behavior in a black child as a discipline issue, while similar behavior in a white child is seen as potentially ADHD-related and warrants a referral. Cultural differences in how symptoms are described or perceived by families can also play a role. It's a complex problem where the biological reality meets societal inequities.
Okay, moving past diagnosis challenges, let's talk about telling ADHD apart from other things. Differential diagnosis. Because lots of conditions can look similar on the surface, right?
Absolutely crucial. Symptoms like trouble concentrating, irritability, restlessness, they overlap with many other conditions. Bipolar disorder, anxiety disorders, PTSD, major depression, even learning disabilities or autism. Clinicians have to carefully rule these out.
How do they tease it apart? What's the key difference?
It often comes down to the reason behind the symptom and the overall pattern. Take forgetfulness, for example.
Down.
In ADHD, forgetfulness is often due to poor working memory or failure to encode the information in the first place because attention wandered, a lack of persistence. In anxiety or depression, forgetfulness might stem more from rumination. The mind is so preoccupied with worries or negative thoughts that it just blanks on other things. The behavior looks similar, but the underlying mechanism is different.
Or like fidgeting.
Right. Fidgeting in ADHD is often about self-regulation, trying to increase alertness or manage restlessness. That's different from the involuntary motor tics you see in Tourette syndrome, or the repetitive, often self-soothing movements, stereotypies, common in autism spectrum disorder. You need a skilled clinician to look at the whole picture.
But even when they do diagnose ADHD accurately, it rarely travels alone, does it? The comorbidity rates are incredibly high.
They really are. It's more the norm than the exception. For kids, something like 2/3 have at least one other co-occurring condition.
2/3. Wow. What are the most common overlaps?
Big overlap with other neurodevelopmental conditions. Around 21% also meet criteria for autism spectrum disorder. And specific learning disabilities, dyslexia, dyscalculia, are found in maybe 20 to 30% of kids with ADHD. Importantly, ADHD itself isn't a learning disability, but they frequently co-occur.
And what about behavioral or mood disorders?
Very common too. Oppositional defiant disorder, or ODD, that pattern of arguing, defying rules, blaming others, occurs in maybe 25 to 50%. Conduct disorder, CD, which is more severe, involving aggression or law breaking, is seen in about 25%, especially with the combined ADHD presentation.
That seems linked to the impulsivity and emotional dysregulation we talked about.
Almost certainly. And then you have high rates of major depressive disorder and various anxiety disorders co-occurring as well. Living with the constant struggles of ADHD can understandably contribute to mood problems.
We also need to touch on the link with Trauma adverse childhood experiences, or ACEs, and PTSD. That relationship seems really complex.
It's very complex and likely bidirectional. On one side, experiencing severe trauma, especially early in life, can disrupt brain development and lead to symptoms that look a lot like ADHD attention problems, hypervigilance, impulsivity. Trauma is a risk factor.
And the other direction.
The core features of ADHD impulsivity, poor risk assessment, difficulty regulating emotions can actually increase a person's likelihood of experiencing traumatic events. Things like accidents, injuries, maybe getting into dangerous situations or having volatile relationships. It can become a really difficult cycle.
Okay, let's talk about a very modern comorbidity. Problematic digital media use, or PDMU. Internet addiction, gaming issues. How does ADHD fit in? That hyperfocus seems relevant again.
Hugely relevant. PDMU is strongly linked with ADHD. And again, it looks bidirectional. The ADHD brain, with its potential for hyperfocus and its craving for novelty and immediate reward, finds the digital world incredibly compelling. Games, social media feeds, they offer constant, instant gratification, which is very appealing when your internal dopamine system is maybe running a bit low.
So ADHD makes you more vulnerable to getting hooked.
Yes, the impulsivity and the pull of hyperfocus make it harder to disengage. But there's evidence for the other direction, too. Excessive, constant digital stimulation might actually worsen ADHD symptoms over time.
How so?
By training the brain to expect constant novelty and instant feedback, it can potentially further weaken the ability to sustain focus on tasks that require patience and delayed gratification, like reading a book or doing homework. It might functionally impair the executive control system even more.
Okay, one last point in this section. Rejection-sensitive dysphoria, RSD. It's not an official diagnosis, but it resonates hugely with the ADHD community.
It really does. RSD describes this experience of intense, almost unbearable emotional pain triggered by the perception, real or imagined, of being rejected, criticized, teased, or letting someone down.
Perception being the key word there.
Yes, it might not be actual rejection, but the fear or interpretation of it causes this extreme reaction, intense sadness, shame, anger, or anxiety. While it's an informal term, clinicians estimate it affects a large majority of people with ADHD. It likely stems from that combination of emotional dysregulation and potentially a history of actual social difficulties or feeling like you're always messing up. It creates this profound sensitivity to perceived disapproval.
All right, we've covered the what, the why, the complexities. Now let's talk about management. Given everything we've discussed, what's the recommended approach according to the research?
The gold standard is generally a multimodal approach. That means combining different strategies, usually counseling or therapy, behavioral strategies, and often medication. And it's really important to state this clearly. The scientific consensus is that medication is the single most effective intervention for managing the core symptoms of ADHD.
The inattention, hyperactivity, impulsivity.
Exactly. And beyond just symptom relief, medication has been shown to significantly improve long-term outcomes across a range of areas.
Like what kind of outcomes are we talking about?
Things like reducing the risk of accidents and injuries, which makes sense given impulsivity, lowering the rates of developing substance abuse problems later on, reducing involvement with the justice system, and even lowering the risk of suicide. Medication helps stabilize the underlying neurobiology, which then allows the person to better engage with and benefit from other therapies and life skills training.
Okay, let's break down the medications. Stimulants first, methylphenidate, amphetamines. They're usually the first thing tried.
Yes, they are first-line treatments, and they work well for most people. About 70% respond positively to the first stimulant they try. There was some controversy years ago, but a major global scientific consensus statement came out in 2021. It looked at tons of data and unanimously confirmed that methylphenidate, for example, is both safe and highly effective when used appropriately for ADHD. It really settled a lot of the debate based on rigorous evidence.
So safe and effective for the majority. What about the 30% who don't respond well, or people who maybe can't take stimulants due to other issues like a history of substance abuse?
That's where non-stimulant medications come in. Drugs like atomoxetine or viloxazine work differently, mainly on the norepinephrine system. They don't have the same abuse potential, so they can be a good option in those cases. Atomoxetine, in particular, has shown similar effectiveness to methylphenidate for kids and teens, although it might take a bit longer, maybe several weeks, to see the full benefits.
Okay. And there are also those alpha-2A agonists, guanfacine, clonidine.
Right. Those are often used either as alternatives if stimulants and non-stimulants don't work, or sometimes added on to a stimulant. They tend to be less potent for the core attention symptoms compared to stimulants, but they can be particularly helpful for managing things like emotional outbursts, aggression, tics, or sleep problems, which often go along with ADHD.
Makes sense. Now, beyond medication, what are the key non-pharmacological strategies? Therapy, skills training.
Absolutely essential. Behavioral therapies are often recommended as the very first step, especially for younger preschool-aged children or those with milder symptoms. Parent management training, or PMT, is huge here.
What does that involve?
It teaches parents concrete strategies for managing behavior, using positive reinforcement effectively, setting clear expectations, improving communication. For older kids, adolescents, and adults, cognitive behavioral therapy, CBT, can be very helpful.
How does CBT help with ADHD?
It targets specific challenges. It can help with managing emotional regulation, developing better organizational and planning skills, challenging the negative thought patterns that often come with years of struggle, and building coping strategies. Medication helps the brain work better. Therapy teaches you how to use that better working brain more effectively.
And technology is playing a role now too, right? I remember reading about a game-based therapy.
Yes, that's Endeavor AirX, or AKLT01. It's actually FDA authorized as a prescription digital therapeutic. It's basically a specifically designed video game aimed at improving attention and cognitive control.
A prescribed video game. Does it work?
The clinical trials have shown significant improvements in objective measures of attention and inhibitory control in children, and some promising results in adults, too. The idea is that the engaging game mechanics repeatedly target and potentially strengthen those underlying neural networks involved in attention regulation. It's a really interesting development in treatment.
Okay, quickly, what about things people often try but aren't really backed by science as core treatments, like exercise or special diets?
Right. So exercise is fantastic for overall health, mood, and maybe some temporary focus improvement. But major guidelines, like from the American Academy of Pediatrics or NICE in the UK, state clearly that it doesn't reduce the core symptoms of ADHD enough to be considered a standalone treatment. And regarding diet, things like sugar elimination, removing food dyes, or using supplements, the evidence just isn't strong or consistent enough for them to be recommended as standard treatments for most people.
Might help a very small subset with specific sensitivities, maybe?
Possibly. But for the vast majority, broad dietary changes aren't the answer for core ADHD symptoms, according to the current evidence.
Okay, let's turn to the long view. Prognosis. We established it's not something people typically outgrow completely.
No, it's generally a lifelong condition. Estimates vary, but maybe 30 to 50% of kids diagnosed will continue to meet full criteria in adulthood. And even for those who don't meet full criteria, many continue to experience significant symptoms. As we said, the obvious hyperactivity might fade into that inner restlessness, and people develop coping strategies, sure. But the underlying challenges with executive functions, self-management, organization, follow-through, often persist.
And these persistent challenges have real-world consequences. Diminished quality of life, struggles in education and work.
Definitely. Worse academic outcomes, on average. More difficulties holding down jobs or advancing in careers. Higher rates of relationship problems, and significantly higher risks for unintentional injuries, car accidents, workplace accidents, things like that.
And the sources also mention a stark statistic about the prison population.
Yes, tragically high rates. Estimates suggest that somewhere between 25 and 26% of people in prison may have ADHD. It really underscores how untreated impulsivity, poor planning, and difficulty regulating behavior can lead down incredibly difficult paths. It's a huge public health issue.
Which brings us to maybe the most sobering finding we encountered. Recent research on life expectancy. This was pretty shocking.
It is. This was newer research published in 2025, according to our sources, and it found a significant reduction in average life expectancy linked to ADHD.
How significant?
The finding was an average reduction of about 7 years for men with ADHD and around 9 years for women with ADHD compared to their peers without the condition.
9 years. That is a massive difference. Why? It's not the ADHD itself that's fatal, presumably.
No, absolutely not. The reduction isn't from the ADHD directly, but from the increased risk of associated health problems and behaviors that often accompany unmanaged or poorly managed ADHD across the lifespan.
Okay, break that down. What are those associated risks driving this?
Well, think about the impulsivity and risk-taking that leads directly to higher rates of those accidental injuries we mentioned, some of which can be fatal. Then there's the difficulty with self-regulation and future planning. This contributes to higher rates of chronic unhealthy habits. Smoking, for instance, is much more common in adults with ADHD, sometimes used almost as self-medication for restlessness or focus issues.
So that core executive function deficit struggling to make choices that benefit your future self directly impacts long-term health behaviors.
Exactly. You also see much higher rates of co-occurring conditions that carry their own health risks. Major depression, anxiety disorders, alcohol, and substance misuse. Again, sometimes these are attempts to self-medicate the internal chaos or emotional pain like RSD. When you combine higher rates of accidents, chronic unhealthy habits like smoking or poor diet, and serious mental health comorbidities, sadly, that cumulative burden takes a toll on longevity.
It really drives home that ADHD isn't just about focus in school. It's a serious health condition with potentially life-altering and life-shortening consequences if not properly understood and managed throughout life. Hashtag outro.
So, to wrap up our deep dive today, we've seen that ADHD is fundamentally a highly genetic neurodevelopmental disorder. It's rooted in how the brain's executive functions work, particularly involving dopamine and norepinephrine systems, leading to those core issues with attention regulation, impulsivity, and hyperactivity. And it can manifest in surprising ways, like that paradox of hyperfocus.
And for you, the listener, hopefully digging into these nuances, really grasping the genetic basis, understanding why IQ scores can be misleading, seeing the reality of emotional dysregulation, and confronting those serious long-term health risks, including the life expectancy data, gives you a much richer, more accurate picture than the old, simplistic stereotypes.
It's a complex clinical reality, yes, but one that's increasingly understood biologically, has predictable patterns, and importantly, is treatable with the right support.
Which leads us to a final thought to leave you with, something sparked by the evolutionary angle in our sources. We know ADHD traits are highly influenced by genetics, and we also know from genetic studies that natural selection seems to have been working against many of these specific genetic variants for a very long time, for millennia. So if these traits have faced negative selection pressure, why do they persist so commonly in the human population? What does that tension tell us about human evolution and maybe the varied environments we've inhabited? And how should that deep biological history inform the current, often heated debate about whether ADHD is purely a disorder, needing a cure, or if it represents a form of neurodiversity that perhaps requires more accommodation from the environment? Something to ponder. Join us next time for another deep dive.